Good afternoon. My name is Michael Myers and I'm the Clinical Support Manager for Contec Healthcare. We've got a little music hanging out in the studio with us there, but we are going to be kicking off our webinar in just about 10 minutes. But before we do, we sort of wanted to roll into today's learning opportunity and tell you a little bit about what Contec's been up to. Now, I know most of you guys are very familiar with our sterile compounding training and resources that we've offered, but we've been working hard to be able to offer these same resources to the non-sterile community pharmacists. And Kedar Patel, our Senior Product Manager, I know a lot of you guys have seen Kedar maybe in some shorts, but not shorts.
Yeah, I was about to say.
But the short learning segments that we do on there, specifically product focused. Briefly, Kedar, tell them a little bit of your Contec history.
Yeah, I've been a total with Contec probably about 23 years in different functions, from R&D to sales management to product management, similar to your career path, Michael, and now you're clinical support manager. So been here quite a long time, learning from the industry and all our grassroots efforts.
You didn't have that gray in your beard.
I don't think I still have.
When you first started.
Thanks.
Yeah, it's coming out on camera.
Wow.
So I wanted to grab you beforehand because, like I said, people are familiar with what we've offered sterile compounders. So many years ago, we just said, let's go see what we're going to take to the community pharmacists. And we realized we just couldn't take the big box of stuff that sterile compounders are using. So you've sort of been in an exploratory, fact-finding for the past couple of years. I know you've had the opportunity to visit some with a lot of community pharmacies. Mm-hmm. What have you learned along that journey?
Yeah, I mean, shout out to those that let me into the door, first of all, because I know they're business owners and they're really busy. So, Josh, Darren, here, and thank you, appreciate you guys. But they give valuable feedback, right? Because this is now impacting them. And as a business owner, they need to understand the standards, or minimum standards, but they could do better. So they've opened up the door, and I'm just kind of learning their challenges versus sterile compounding, right? Sterile compounding had that event that happened, and now it really highlighted the needs for that employee safety too, with those that are dealing with hormones and hazardous drugs.
And you kept continuing those. I know you got the opportunity to go to a couple of conferences that are focused on community pharmacy.
Absolutely. I just came back from one and spoke to many of the attendees today as well. But learning more about their challenges, some of them are new to the standard and understanding it. They maybe just graduated, getting into compounding, to those that are legacy, where there might be some challenges of their facilities and wanting to upgrade. So a lot of them are looking for that trusted resource so that we can help them. And that's what we're here to try to help do today.
What surprised you when you started, because we both, through our Contec careers have worked in clean rooms, and that really, transponds to USP 797, sterile compounding. But community pharmacy, it's stepping out of the clean room a little bit. What surprised you most about learning?
Just the fact that I mentioned to you, they're business owners, they're making an impact in the community. There's a lot of relationships that they have, and they want to do right. So it's just a matter of them understanding and trying to understand what to implement. That's what I really got out of it. There's, again, old school fountain shop type of community pharmacies. That's a place for people to congregate, all the way to those that are also investing in the sterile compounding.
Yeah, it's right in the name, community pharmacy, locally owned usually, and servicing folks in that community. So yeah, it's a great aspect. And I know, at the end of today's webinar, we're going to have dwell time where we'll have our other product manager, Rachel Davison, along with one of our field experts, Todd Hardy, on. And they'll talk about some real world applications of these Contec products in community pharmacies. And you'll have the opportunity if you want to get samples, for example. But I know we didn't get there overnight. So again, we couldn't just take the box of stuff that sterile compounders were using. Talk about, as product manager, us developing the product specifically for community pharmacy.
You nailed it, because it's not cookie cutter, right? These are unique challenges, especially when they're dealing with powder substances. So that's with the hormones. So that's a really big challenge of how do you control that? How do you pick that up? What are some of these terms like deactivation and decon or decontamination? How can we do that? What's the agent? What does sanitize mean? So there's a ton of resources that we have developed to help. But like you mentioned, we can't just bring over what has worked in the sterile compounding. It's got to be cost effective. As I mentioned to you, it also, these are business owners. So this added expense of the small section that they need to focus in on continues to grow. So how can we get them the right tool to do the repeatable process? And I know you're a big advocate of that.
Yeah. Well, again, after today's education portion, we are going to do our dwell time, our post-webinar segment that will really dial into some of the details on these products that Kadar's been working on developing. But just so they can bookmark it, where can they learn more about this stuff? Any resources they can go grab?
Yeah, absolutely. You're about to meet one of them that's going to be speaking here shortly. But also go to Contec Healthcare. We have a link that you can go to that's find your local healthcare representative. Ask questions. We field those questions. We work hands on and side by side with you guys. So we really want to be that trusted resource for them. They can learn more at Contec Healthcare. And then as we continue to develop data-driven reports, more collateral, and more products.
Excellent. All right, so we're about to kick off our webinar. Do you briefly want to tell folks what they're going to be hearing about today?
Yeah, absolutely. So as we mentioned, this is a non-sterile focused on community pharmacies, but specifically also those that are in Canada and the US dealing with hazardous drugs, which are hormones. And that might be a shock to some people out there, but that reality is here, and we have a tremendous expert here to talk about it.
Yeah, I think a lot of people, when you say HDs, they automatically are jumping to sterile, compounding 797, 800, but there are non-sterile 795, 800 considerations. So yeah, we'll be getting into all of that today. Kadar, I'll see you in a little bit.
Absolutely.
We'll both be participating in today's things, but our main speaker is Melanie Dory. Melanie is the president and founder of Critical Compounding Resources. She's been training pharmacists across the US and Canada. So before we get going, I'm going to jump back here to the control room just so everyone can sort of at home can get an idea of what we're looking at. So right here is Studio 289. Melanie's in the back. We'll be doing our panel. We'll be able to submit your questions in the chat for the webinar. So at the end of today's webinar, we'll gather all three of our presenters back here around the table and answer your questions at home. Right through here is our control room. I've got to give a shout out to Daniel Crow, Jody, we've got Dylan, Ryan, Chris is trying to sneak through the door down there, and Rachel. So please stay tuned at home, get your questions in the chat, and I'm going to hand it off to Melanie now.
Thank you so much for the great introduction, Michael. I'm so happy to be here. I also want to thank Contec for having me out to do this webinar. I am Melanie Dory. I've been a pharmacy technician for over 20 years. I am based in Canada, but have participated in training both across Canada and US in sterile and non-sterile compounding. So I'm really happy to be here to present on this subject matter. Now, we are going to be focusing on hazardous drug non-sterile compounding. I think when we looked at the 300 questions that were submitted, that was definitely a main topic of discussion. I do also want to be very clear that what we're going to see today is only a drop in the bucket of the ocean of knowledge that is out there to help support people as they're either embarking in this adventure of doing hazardous drug non-sterile compounding, or if you're someone who's already been doing it and needs guidance, this will be a great start, but you will absolutely need more information and lots of training to make sure that you can take this on in a safe way to protect yourself, but also providing patients a very high quality preparation that they deserve to get as well. Another thing, Michael mentioned that we are in a studio, so we did our best to make this look as much as we could as a non-sterile compounding facility. But as you can tell, it has the fit and finishes of a clean room. I just wanted to take that and mention that so that no one's really shocked or surprised why this looks more like a sterile compounding environment. But we do have great equipment that we're going to show you guys today, so that's going to be great. So let's get started. So what are we really going to be discussing today? What are the specifics? So we'll talk about the standards that apply to non-sterile compounding. So again, we have a lot of participants here from the US and Canada and some from the rest of the world as well. So there is going to be mention of USP and NAPRA, so we'll talk about those. And then why do we need to be compliant with those chapters? Why is it so important? Why do we keep kind of talking and bringing that forward? So we'll definitely talk about those details. And then occupational exposure. So, when we talk about hazardous drugs, there's a different level. It's not just providing patients with a good preparation. Now we're talking about personnel protection. So all the people that compound, or the pharmacists, the pharmacy technicians, pharmacy assistants, we need to make sure that we offer them good protection. and then how to prevent cross-contamination. So we'll talk about the resources, what products are out there to help you do that, the PPE, and we're going to dive into all of those details coming up. So I am going to talk about that it's not just compounding. When we refer to hazardous drugs, there's a lot more that we have to consider here. And if we look down at my little examples, I have a few things here set out just to show you guys. So, we're going to talk about counting hazardous drug tablets. So when we're counting hazardous drug tablets, it is not considered by USP 800 as a task that needs to be done in full compliant, full containment strategies, like in a CVE in a room, but we need to consider the particulate generation that can happen from this. I also have splitting HD tablets, so a tablet splitter, like where would we be doing those tasks? When we do reconstitute HD oral solutions, every time we add the diluent to that bottle of powder, we always get that release of powder, that little cloud of powder that gets released in the environment. We should not be breathing that in. That's not healthy for us. And then what about drawing up oral HD liquids? Often in pediatric hospitals, we'll unit dose our syringes for the patients. So that is a task that takes place. So do we need to do that in full containment, or can we do that with the right PPE on a designated countertop? So some of these questions I can't answer fully for you because it does depend on a risk assessment, but I just really wanted to highlight this, that it does go beyond compounding, that we do have to think about every single hazardous drug component, hazardous drug preparation that comes into our facility, do a risk assessment, and kind of think of it as a whole entity. All right, so let's move on. So who prepares non-sterile compounds? Well, the first thing to mention is that non-sterile compounding is one of the oldest types of compounding in history. It dates back all the way to the Egyptian times. Think about the apothecaries that were out there. So we know that is something that we're all very familiar with in the pharmacy. It's one of the first things we learn when we go to pharmacy tech school or in pharmacy school. Community pharmacy does it. Specialty compounding pharmacies can perform it, even in the hospital setting. So I know Kadar went to visit a lot of community pharmacies, but we also perform a lot of non-sterile compounding in hospital practices as well. So we need to consider all of that. So now let's talk about the specific chapters and the regulations that are out there. So for the US, we have USP Chapter 795, and we also have USP Chapter 800. So 795 is going to guide us and have our standards for non-hazardous drugs, so non-HD, non-sterile preparation compounding. So that is great. What they do bring forward is a lot of information as well when it comes to respiratory protection. So anything that could generate particulate or dust in the environment. So could be crushing tablets, weighing out APIs, so we need to also consider that. It may not be hazardous, but it still could be an issue for occupational exposure. So we don't want to forget about that. And then 800 is going to take us on the hazardous drug non-sterile route. So Kadar mentioned the hormones, and I have a few slides on hormones, but we also compound hydroxyurea suspension. We also compound 6-MP, we split tablets, we do so many other things. So we need to make sure that we think about all of those hazardous drugs, okay? So one of the things to mention about US as well is that the USP chapters doesn't just apply to pharmacy professionals. It does encompass all of the industries that may do non-sterile compounding. So we're talking about nurses, physicians, dentists, veterinarians, naturopaths, chiropractors. So anywhere and any of those people that are doing and preparing non-sterile compounds, the USP 795 and 800 would apply to them as well. So now let's move on to Canada. So we have our NAPRA Model Standards. So those are the standards we have to follow. We have two documents that NAPRA published for us. We have our NAPRA Model Standards that was published. So again, that does talk a little bit about our non-hazardous and our hazardous non-sterile compounding. Then they published a guidance document, which again, it was up to each province in whether they were going to incorporate that guidance document in the policies that they were going to regulate. But the guidance document had a lot more details for especially when it came to hazardous drug non-sterile compounding. One little note I want to mention is that NAPRA did come out with draft documents, one for hazardous and one for non-hazardous. It is, again, in draft. So when you go and read them, just make sure you're not implementing all those changes because they could change before they get released as final versions. But yeah, they were due for public comment March 15th. But if you are doing non-sterile compounding, it would be great for you to go read, especially the non-sterile one. But again, don't implement any changes until we have an official chapter. NAPRA only applies to pharmacy professionals that take on these tasks. So NAPRA does not oversee nurses, physicians, or any veterinary practices when it comes to this, okay? So now when we transition to speaking about hazardous drugs, you know, why am I making such a big deal about occupational exposure? Why am I making a big deal about following containment strategies for non-sterile hazardous drug compounding? Well, it's because we have this data that dates back to all the way to the 1970s. So we reported in the 1970s secondary malignancies that were identified in patients following their treatment. So they were getting these secondary effects from their treatment. Now we transitioned to the 80s where there was you know, associations between exposure for and adverse reproductive effects. So now we're talking about occupational exposure in the 80s. You know, now people were reporting miscarriages, congenital malformations, low birth weight, infertility. So those are very serious problems to have. And then in the 90s, that direct link to occupational health was made with the exposure to hazardous drugs. So what I'm going to say here is that we can no longer ignore. We have 56 years of data telling us that being exposed, even if it's at a low amount, but over a 30-year career, it could potentially cause us some serious health effects. So we can't really ignore what's actually happening. We have to do right by our employees, we have to do right by ourselves, and implement the right tools in order to protect our staff and ourselves. So now we know hazardous drugs, what can they do? Well, they can cause cancer, organ toxicity, they can cause fertility problems, genetic damage, birth defects, so all of these not great things. So we need to do better. What's important to note is we have to think about the entire life cycle of the hazardous drug. We can't just think about the compounding or the counting. We need to think about how we receive these medications, how are we going to store them, how we transport them from one place to another, even when we're transporting them out of our pharmacies into maybe patient homes, and even administration. So, you know, we need to support our patients when they get discharged or they get sent home with a new prescription for an oncology product or a hazardous drug on if they have family members in the home or pets. So we need to educate them on those occupational exposures, okay? All right, so NIOSH Alert came out in 2004. Everyone's familiar with this graph, and if you're not, it's an absolute great graphic. It talks about a hierarchy of controls, which is amazing. You know, we have these 5 controls that they list here. The first 2 definitely don't apply to pharmacy because unfortunately, if a patient is told they need this treatment or this medication, we can't eliminate it. They need the medication, and very rarely can we substitute that medication. So we're going to be living in the bottom 3 sections here where we talk about engineering controls, which is going to be the room or the CVE or the BSC that we're going to use to protect us and the environment, and then PPE. The PPE is going to be our last line of defense. But there's a lot more to this story. We need to add, there's many more layers. So I've listed some here, and this is another just little part of the list. But again, I mentioned PPE, but we're really going to want to focus on hazardous drug PPE, which again, I'm going to talk about in the next few slides. Respiratory protection, decontamination, which I'll define and discuss with you later. Doffing, same thing, I'll define and discuss with you later. Also, hazardous drug wipe sampling. Like, can we detect any hazardous drug residues on these surfaces? That could be a great tool, and yes, should be implemented, and even if you're doing HD non-sterile compounding, and doing risk assessment of your facilities and the types of compounds and components that you're bringing into your facility. And then the storage and transport, handling spills, like the list can go on and on and on. So make sure that you're thinking of that entire life cycle of the hazardous drugs. Now, at the end of the day, our patients deserve a high quality, safe preparation. But when we're doing hazardous drug, we have to consider staff and how we can protect them. So we don't want to expose our staff to those hazardous drug residues and potential contaminants. We want to keep them safe. So this is a 2-part, right? We have to make sure the patients are getting something safe, and that we are protecting our staff. That is so important. So what are we defining as hazardous drugs here in non-sterile compounding? Well, of course, any hazardous drug that's found on the NIOSH tables of hazardous drugs. So we have table 1 and table 2. And then when we talk about the NIOSH list though, there's a little caveat. You've got to also think that the NIOSH list was published in 2024, but they only have published for medications that were released up until 2015. So any medication that was brought to market after 2015 that is potentially hazardous will not be found on that NIOSH list. You will need to do your own review of those medications post 2015 and assess them for hazardous drugs, and like, do they have a MSHI? Are they on the IARC list? Like, you'll need to assess that yourself, okay? Now, here's the other thing. I talked about respiratory risk, like dust creation, particulate. So we need to think about that as a respiratory risk for ourselves. So when we're crushing tablets, when we're weighing out APIs, we create dust. You might be able to visually see it, but some of it you won't see. It'll lift up into the environment. And there is no safe amount of those APIs or those crushed tablets or opening up those capsules. There's no safe amount that is allowable for us to inhale. And again, it's not just, oh, one time I did that. It's because some of us that are tasked with non-sterile compounding are doing maybe a few hours of it every day or every other day, again, for a very lengthy career. So we really want to think about that respiratory risk. What's great is that 795 does mention that whenever we're doing any type of particulate generating activity, that we need to consider having a closed system processing device, and I'll talk about those later on. And NAPRA does also talk about doing anything that's going to generate particulate, to consider having a CVE or a CPEC that would offer protection. So that's great things. It is mentioned in the requirements. So let's talk about the facility requirements for US. Again, we're really going to focus here on some hazardous drug, but I did include the list of what 795 would require. So we're going to talk about somewhere that's well lit. We have to maintain it in a clean and orderly fashion. We want to minimize cross-contamination, no carpet, temperature monitoring, and then we need access to a sink with hot and cold water. As we know, we have to clean those utensils. We have to be able to wash our hands. Now 800 has a bit more information. It does mention on having a CPEC in there. We'll talk about what exact types of CPECs that we want. Again, this one will have, the room will have to be externally vented. It needs to be a physically separate room. So 795 doesn't talk about a physically separate room, but 800 does. So 4 fixed walls and a door. We've got to maintain a negative pressure of 0.01 to 0.03 water columns. And then we want at least 12 air changes per hour. And then they added, on top of having the sink, we're going to need access to an eye wash station. Again, when we talk about best practices here, if you do build out a room for hazardous drug storage, which will have to be 12 air changes per hour and also that negative pressure requirement, well, you already have the requirements of what you would need for a non-sterile compounding room for hazardous drugs. So what you could do is, if you're building out a hazardous drug storage room, make room for a CVE for your non-sterile HD. It has both the same requirements, so that room can offer you a 2-for-1 deal here. Now, what we need to also think about is that sometimes, especially in hospital settings, we are going to have that room also have a pass-through that's going to lead to our buffer room, or hazardous drug buffer room. So now we're talking sterile. So I would want everyone to consider having the CVE at the other end of that room and not be so close to the pass-through that would be going into our sterile environment. So just be very careful to not butt those two up together, because sterile environment, we wouldn't want any particulate generating activity to be near that pass-through. Again, I'm going to make this recommendation. If you're doing non-sterile hazardous drug compounding and you can't accommodate everything I've listed here in a facility, then you can't offer your employees protection. So it would be best to outsource that prescription to a facility that does have that built out and they can accommodate for hazardous drug non-sterile compounding. So for Canada, it's quite similar. There's a lot more requirements here. So, we're going to have negative pressure environment, good ventilation, eye wash. So some of the things are very similar. The guidance document provided a lot more clear guidelines, but again, very similar to what 800 said. So we're going to have that 12 air changes per hour. We work in a metric system, so we're measuring minus 2.5 pascals to surrounding areas for our negative pressure. Same idea, sink with hot and cold water, 22 degrees. And then they did mention to have the sink a meter away from any type of CPEC. And the best practices are going to be the exact same that I've already mentioned. All right, so let's talk about closed system processing devices. So let's talk about what NAPRA requires, but you're going to find similarity in all three, okay? So the NAPRA Model Standards and the guidance document, so we talk about CPECs that are going to be externally vented, or we can have them go through redundant HEPA filters as long as they're in series. We're also going to allow a Class 1 BSC, a CVE, a Class 2 BSC, CACI. Those will all be allowed. And then there is this caveat where we can use occasionally the sterile BSC for non-sterile preparation, but that word occasional is in there. It's hard to measure the word occasional. So one facility's occasional may not be the same for someone else. So I find if there's a routine to the amount of compounding you do, you may want to consider having a separate suite for your non-sterile and not share that BSC. There is a level of risk, and there is going to be a full procedure on deconning and doing a full wipe down even under the work tray before sterile compounding can resume. So that would have to be documented in the policies, and training would need to happen because non-sterile compounding is very risky to sterile operations. So 795, like I mentioned, does talk about that generating of particulate. So it does recommend a closed system processing device. So they offer a CVE, a BSC, or a containment glove bag, which is a single-use item you can use. Again, going to 800 now, same thing, Class 1 BSC. We're going to have the CVE, a Class 2 BSC, or they also list a CACI, which was also listed in NAPRA. Again, externally vented, or it could have the double redundant HEPA filters in series. And again, they also have that allowance for occasional use of the sterile BSC for non-sterile compounding. So what I'm going to do is, we're really lucky that we have a CVE in the studio with me. So I'm going to talk about this CVE. Again, this is a great tool to have to offer respiratory protection, to offer us protection as the worker, and also offer protection of the environment. This specific example does have that double HEPA filter in series. The other options are to have it ducted to the outside via canopy, so that's another option. They're great tools to have. This one is on a stand. You can get them as countertop versions. So again, if you're a small retail space, you're not doing HD, but you want to protect your staff from particulate generating activities, you could get a countertop CVE. If you're splitting any type of hazardous drug tablets, you can do them in there to protect your staff. Anything like that, it's going to offer full protection for your staff. So it is a very good tool to implement into your pharmacy for doing any of these activities. All right, so then we're going to be able to move back along here. So there is certification, there's like maintenance that needs to be done on the room and on the actual units themselves. So we're going to have to involve our certification professionals here too. So I listed some of the tests that we would have to do for our negative pressure non-sterile compounding suite, and then also for our PECs or CPECs. So whether they're a BSC or a CVE, they need to see the certifier every 6 months, and I listed here what they would have to follow for certification process. But again, I'm not a certifier, so please reach out to them. They're the experts, so we can get that done on a regular schedule of every 6 months. So I'm just going to do a little intro here about PPE. So our goal is to protect staff from exposure to HD residues, okay? So PPE is going to be our last line of defense. We're going to want to make sure we're using the right PPE as well. It's not negotiable. If you're taking part in non-sterile HD compounding, you're going to have to use the right PPE. And then how much PPE you wear is going to depend on what type of compounding you do. Like if I'm splitting tablets that are non-HD, like do I have to wear full garb? Of course not, but you're going to have to do a risk assessment depending. Oh, do I have to wear hair cover? No hair cover. Again, we're not doing sterile compounding here. There's not a heavy microbial risk. Though we still want a clean area and we still want to clean and disinfect, you can do a risk assessment when you're going to do. Most of those big specialty compounding pharmacies are probably going to use a lot of garb, because they're probably maybe extending BUDs. but for the most part, you get to decide what you want to do. Now, for hazardous drugs, we don't have as much decision because we want to protect ourselves. So let's talk about PPE. And what I'm going to do is I'm going to invite Michael back in because he's so wonderfully volunteered to be, he volunteered to be my show and tell. So let's talk through what is actually Michael wearing. So he did, we said it was optional for the hair cover. Again, your facility is going to make that decision, but Michael's wearing one today. He's wearing a procedural mask. The other option is an N95. N95 does offer protection against particulates, but we need to be careful. It does not offer protection against vapors. So that's something to note. Michael's also wearing the Contec chemo gown. It's traditionally, you see it from the blue stripe, and that is offers chemo protection we have data on it, which we're going to see in a little bit. He's also wearing 2 pairs of gloves. We want to wear 2 pairs of gloves when we're doing hazardous drug compounding, and we do want them to be ASTM rated. I will talk about that rating in a little bit so we can make sure we understand that well. And then if we look at the shoe covers, he is wearing 1 pair. These are water resistant shoe covers. I'm going to talk a little bit about the differences between the water resistant and the linen shoe covers. So that is very much, and the fact that they're white, you can really tell the difference. So they're going to offer great protection, especially in hazardous drug environments. If you're not doing hazardous drug compounding, you may not need to use the water resistant shoe covers. A blue linen shoe cover might be okay. You may decide to not wear shoe covers, and that's fine. You have to do that assessment for your facility. Okay, Michael, I have to go through a couple slides, and then I'm going to use you again, actually. Okay, so again, the gowns are going to want to be ASTM rated to F3267. Again, that was released in 2022. I have a whole slide on that ASTM rating, so we'll talk about that. Now, those water-resistant shoe covers, the reason why we do recommend them, and we use them a lot in sterile compounding where we have to wear 2 pairs of shoe covers. If we wear the blue linen ones, what we saw, and we've done studies, is that some of the hazardous drug residue could absorb, because it's very absorbent, that blue linen, and actually track all the way up to the bottoms of your shoes. Now, if the goal is to contain hazardous drug residues into that negative pressure environment, and we have contamination of hazardous drug residues that's all the way up to my shoes, even if I remove the blue linen shoe cover, I'm still going to be tracking that hazardous drug residue out. So that's why the water-resistant seamless shoe cover works really, really well. So we definitely recommend that type of shoe cover in any hazardous drug environment. Now, we also recommend this PPE takes place in anywhere hazardous drug storage are stored, any handling that happens. So of course, in this environment, we want to make sure that we're fully protected. So yeah, and then that gown's super important. Now, remember I said, make sure you do a risk assessment, make sure you gown and garb according to what your facility is doing and the types of compounding you're doing. If you ever need any help with this, the NIOSH released a managing hazardous drug exposures. They have information for healthcare settings. And it lists at the end, it has a great table, and it lists for different activities. And even for nursing, if they're administering, it has so much great information. So if ever you need, like, hey, I'm cleaning, do I need 2 pairs of gloves or 1 pair? It has all that great information. So please use this document. It is a great, great tool. So now let's talk about this ASTM rating. Again, this is relatively new. It was released in 2022. So ASTM released a testing protocol that can test for liquid chemotherapy and liquid hazardous drug permeation. So of course we would want our gowns tested that, make sure there is no permeation. Since this is a newer protocol, not all manufacturers have done it, but I know for a fact Contec has tested their gowns to that rating. So that's great news. So if you know that if they've tested those gowns, that we are certain that the permeation of that liquid hazardous drugs will not go through the gown. So great news. So let's talk about doffing. I just told you, okay, we don't want any of that hazardous drug residue migrating out. We want to contain it in the containment secondary engineering control or in this non-sterile hazardous compounding room. So we need to create a way where we could remove our PPE in a specific sequence that is not going to allow that contamination to potentially migrate out. So we're going to make sure that whatever steps we create, we're going to include that in our SOPs and train our staff. But I have some steps here that I'm going to share with you. So here on the screen you can see the steps, but I'm going to welcome Michael to come right back in, and we're going to talk through the steps together. So Michael, we're going to assume he's left the CVE and he's already removed his outer pair of gloves, because I want to be very clear. After we're done doing our hazardous drug compounding and we're deconning everything out of it, we are going to remove that outer pair inside the CVE. So now we're going to take it live to this part. So
and I put that first pair of gloves under the chemo gown cuff on top, and then the second pair of gloves. So I doff that outer pair of gloves in the CVE. I'm left with the one pair of gloves under the cuff of the chemo gown.
Absolutely. So then Michael's next step now is going to be to doff the gown. So you're going to watch him, because Michael, I think you do some very specific.
Yeah, I don't really want to take my hands and start reaching around behind my back and rubbing. So I usually just come up to the shoulders and we'll pull directly out. And what that will do is pop off. Now, what you won't have happen at home is have a lapel mic clipped onto your gown. And because if I tried to roll out of that, and then you clip your lapel mic back on, you'll do that just at your facility. You'll take that lapel mic. So what I'm doing is being very cautious as I sort of roll this gown, is to roll the outside in. So if there were any contamination on that gown, I would sort of capture it and sort of being very deliberate with how I roll and ball that up. And then I do want to put that into my trace waste.
Yes, that's also very important. Trace waste for our Canadians, it's usually a red cytotoxic waste. So whatever is your local jurisdiction and what they require.
Yep.
So then, Michael, we made this makeshift doffing line here on our floor. So that's what we're going to need. We're going to need that clear line to be able to have staff know where we're considering there's hazardous drug residue and where we're considering there's none. So I'll have you do your shoe covers next. So that would be appropriate.
Yeah, and similar to when I was taking the gun, I don't want to sort of reach behind. I don't want to really just start digging around inside of this. So I usually like to come and just sort of pinch, make sure people at home can see this, pinch from the outside, and then I can pull it off. I'll put that into my trace waste as well. And then I want to do the same thing on this side, sort of pinch from the outside, remove that shoe cover, put it in trace waste, and now I can stand up on the other side of that perimeter line.
I think it was very important to understand that they are slow, methodical steps when we're stepping over. Shoe covers, no shoe covers. So exactly how Michael did it.
Yeah.
So then technically what we would want is have Michael leave the room now. He could exit, but let's just talk through the final steps. So the next step would be the gloves, but please realize how Michael is going to do it so that he's not contaminating his skin.
So again, I really just don't want to start digging around here skin. So I will usually go into the palm of one of the gloves and pinch it, sort of grab a hold of it, and then I can pull that glove off. My hands are a little sweaty here. And then I ball that up into the palm of this hand, and now with my skin to skin, I can go over and pull that out, and it kind of makes like a little containment that I can place in there as well.
Awesome. And then the last steps would definitely be to remove the mask, and if you have the hair cover on. But same with the mask, we don't want to grab the mask from the front, because what if it filtered out particulate matter? So we really want to grab it from the ear loops and
so
take
I'll pull
it
off
off.
the bouffant, that's first, and then I'll just come behind and hook the thumb loop or the ear loop with my finger, and then I'm able to remove the rest of that mask.
Yeah, so I think it's as simple as that. Thank you, Michael, for helping me with that. All right, so let's continue on. So that's kind of the steps for doffing. Again, it would be great for you to implement that at your facility and write out those steps. Create a doffing line. In sterile compounding, it's complicated to create a doffing line. We have to heat weld it into the floor, but in non-sterile, there is a specific type of tape you could purchase and be able to kind of separate out an area. And you would want that to be on the inside of the room. So it shouldn't be the doorway as you leave the environment. Otherwise, it makes it hard for people to balance against an open door as they're walking out. You just want it to be a little bit inside of that door. They can do the steps and then open the door to exit out. Okay, so decontamination, deactivation, and disinfection. So we want to think about cleaning and disinfection. So first, let's talk about deactivation and decontamination. So we hear the words often interchanged, or sometimes they're not really properly used. And you know, it's great to have standards out there, but I feel also the word deactivation was very overly used. So let me talk about deactivation. So deactivation is we want to render that chemical, that hazardous, inert. So to do that, Every single drug will have a specific chemical that they're going to require in order to make that happen. In pharmacy, we don't like that. We're not going to have a shelf of all sorts of cleaning agents and deactivation agents for all the different 60 or 70 drugs that we compound. We can't be like, oh, sodium thiosulfate for this one, sodium hypochlorite, peroxyacetic acid. We can't do that. It's too much work and it's too much managing of all those chemical agents. So it's much more realistic for pharmacies to do decontamination, where what we're doing is transferring the hazardous drug residue from the target surface onto the wiper and then discarding that. That's what we are going to do, and that's what's most important. And we're going to want to select the proper agent for the activity that we're doing. So for those of you who are not familiar with decontamination, this is something that's going to apply to you if you're doing non-sterile HD compounding. We need to make sure that everything that's coming out of that CVE is going to be decontaminated, whether it be the equipment, whether it be the final preparation. We need to make sure we have decon procedures, and then high touch surfaces and everything that's part of your cleaning is going to need to be decon as well for hazardous drugs. So it's a term we need to be familiar with, okay? Even when I talked about those pill splitters and the counting trays, those will be dedicated to hazardous drugs, and you're going to need to implement decontamination steps as well for those. And then maybe adding a water rinse because you are going to be counting tablets that are going to be taken orally. So we're going to want to make sure we rinse off the peroxyacetic acid or any other type of decon agent. Okay, so let's talk about compounding for hormones. So everybody, listen, we've been compounding hormones for decades, okay? Even I've been a pharmacy technician for 20 years, and even before that, we were doing hormone replacement therapies. We do capsules, we do suppositories, creams, ointments, gels. It's like all the formulations that can be done are being compounded in pharmacies. But hormones are scary. Even though they're not considered a hazardous drug, they're considered a hazardous drug, even though they're not considered an anti-neoplast, or an immunosuppressant or another type of hazardous drug, they're still hazardous. So hormones can cause reproductive toxicity. They can do teratogenic or carcinogenic effects. Even with low repeated exposures can cause organ toxicity. They're also very highly lipophilic, so means they can cross easily across the skin and get absorbed into our cells. So that's why they're a little bit more scary than some of the other ones we handle. So since they're different than anti-neoplasts and other common drugs, they're still found on the NIOSH list, the HD Table 1 and Table 2 list. So they are hazardous to our health. So we need to be very careful about this. That means if they're on the hazardous drug list, we need to follow our compliance, so our documents, whether it be USP or NAPRA, in order to protect ourselves. I did put up this study here, and I think that one is from 2013, and it does talk about pharmacists, nurses, and technicians that were exposed to those APIs of hormones having a negative health effect. So again, this is from 2013, so you know, we're talking 13 years ago this was published. So there is the information out there. We need to be careful. We need to protect our staff. So what is our recommendations? Well, hormones need to be treated as hazardous drugs. So they need to be handled with USP 800 in mind, and then for Canadians, level C compounding in mind, okay? So we need to make sure that we're following full containment strategies, full separate room, negative pressure, 12 air changes per hour, having a CPEC, all of that applies, PPE, everything. So now we're gonna talk about PPE. Well, it's a hazardous drug, so I'm gonna just wear the ASTM rated PPE for the hormones. It's actually not that simple. Hormones, since they're different than anti-neoplasts and other common HDs, they love to absorb. We're making them in a cream base. It makes it more permeable. It's not that simple. And the ASTM methods, testing protocols, do not list hormones in those testing protocols, so they only test for anti-neoplasts. So what are we going to do about this? So what I'm going to do is invite Kedar to join me, and he can talk about the data.
Hey, thank you, Melanie. So you mentioned it earlier in the webinar, right? These are the previous drugs are tested in liquid forms, right? And we're dealing with powders, and it's very difficult to test that within the ASTM, method of what we have now. So I'm going to kind of talk a little bit about it. The 3267 has its limitations, and we already talked about it. It's not on the hormones. The hormones can't be tested there because of that powder and the cream. Think about that. Trying to run it through some of these machines, you could really mess it up. So Dr. Mark Weinsick, I don't know if we can cut to him in the control room, but I know he's in there. He's listening. He's making sure I don't say anything stupid. So just want to make sure that he gets a kudos to this, because he actually came up with a novel test method for us. We're using different types of the hormones, and we used a vehicle to actually spread on the surface and including the seams, you know, trying to test this as a worst case. So he was able to help us identify that we could wear our gowns based on you know, this test method, because we swabbed the backside for about 30 minutes or less. Okay, now that was the initial time that we tested, and this is assuming that you get it on you too, right? I love your analogy. I think you talk about baking and whatnot, so you can't see this, so you have to assume that it might be on you. Tell us a little bit about that.
Yeah, so I do refer to non-sterile compounding as if it's like baking, because sterile compounding, we're taking things out of vials, it's a bit more controlled. We try not to have spills and leakage, whereas non-sterile compounding, when we're making those creams and suspensions, there's a lot more risk of it getting onto our arms. And my little thing is, how often when you're done baking brownies, like you walk away and then all of a sudden you find a little bit of chocolate over here on your arm. So, you know, those creams, those powders are white, the gown is white, so you may not see how long it's been on there. So it's good that we know that we have that number of 30 minutes. Yeah,
so that's really what we want to try to adhere to. So the one thing I did want to talk about though is the detection limits, right? So even though that we say 30 minutes, the ASTM methods, you know, the D6978 for the gloves as well as the 3267 for the gowns, have a limited detection method.
Yes.
Okay, so what Dr. Mark again mentioned, I can see him through the window over here, so thank you, Mark. He was able to show the blockage of the hormones put on there. And if you look at the numbers there, you can see that's a pretty significant amount that's being blocked from a known amount that we put on the outside. I would encourage those out there to contact the rep, and we can walk through these details, but this is data-driven science, because we can't just go to a third-party lab and say test to this you know, 3267, because they'll be like, well, you're gonna buy me new machines because I can't test this, right? So we had to come up with something, and I know you were a big proponent of driving that, especially in Canada. I don't know if you want to talk a little bit about that.
Yeah, no, I'm very thankful that when I did approach Mark about the gowns and getting data for the hormones, I'm just so happy that he was able to design this testing protocol so we could actually start with having some data. As we mentioned, the ASTM protocols don't list hormones, so how do we know we can protect ourselves with that specific gown if we've never tested for those hormones? So I'm happy that we do have some recommendations.
And it's all about that worker safety, right? That's all we're trying to do is show so they can make an educated decision.
Absolutely. So I'm just going to move on. Hang around, Kedar, because I'm going to need you to talk about some decon data too later.
Okay.
So talking about gloves now. So should we double glove, change frequently? Well, yes, it is a hazardous drug, so we're going to want the double glove. Again, same message here. The ASTM protocol for gloves also doesn't list hormones. So again, a lot's gonna go into that, like the type of the material of the glove, the drug properties, so we know that the hazardous drugs are lipophilic. So we know from what I've seen in research from some of the manufacturers, and I haven't researched all manufacturers, it was really hard for me to find any hormone permeation data. So we need to be really careful. So again, I can't speak to a data-driven recommendation here. What we did is we discussed with a lot of experts. So our recommendation would be to use some sort of nitrile glove, have it be ASTM rated because at least it's been tested for some permeation of other hazardous drugs, double glove, and then maybe change out that outer glove every 30 minutes because I don't have any other data to tell you, no, this glove will be good for an hour. But what we will encourage you to do is talk to your manufacturer. So whatever glove you're using, call the manufacturer. They may not have just published the data. They may have it and can share it with you, but they may not have published the data. So please reach out to your glove manufacturers. Maybe they have data saying they're good for an hour. And again, just make sure it's for the hormone that you are compounding. Because again, let's go back to that 30 minutes. That would be kind of the time you would want to use.
Yeah, and I would encourage you also to look at the concentrations that they're putting there, what kind of test method they're trying to follow, because there's a lot of different ASTM methods that potentially could be used, but may not be indicative of what you're actually compounding with. So just be mindful of the details because it is in the details.
Absolutely.
So we talked a little bit about the decontamination. Again, you know, kudos to the tech service team here at Contec because Mark also helped drive this as far as a decon. We're data driven. You know, in the sterile compounding, we have protocols that we use for those, and we demonstrated on some of the stickier drugs. So we consulted as well with many of the industry experts like yourself, and we talked about what do we want to test, right, and on what type of surface. So we were able to demonstrate, again, a significant log reduction or removal, because again, we're trying to do the physical removal of the residue. Can't chase deactivation. I know a lot of people want to use that term, or maybe even on an audit checklist, do we have an agent that deactivates? I'm sure you can have like one buzzword or one drug that it does, so it checks the box. But even in, you know, and you'll hear it in dwell time later today, you know, 800 says you can't chase that. You have to chase decontamination. So that's what we wanted to do, is just go ahead and share this information as well. And we come out and show you how to use these products as well. So I think that training is very critical because as we mentioned earlier at the webinar, a repeatable process with the right tools, you're spending your money after the consumables that can make a difference. Okay?
That's amazing. So again, you guys tested on specific materials for countertops that we would more commonly see in non-sterile.
That's exactly right. That's exactly right.
That's amazing. Again, and that's what's great about Contec is that they continue doing, like anytime I talk to them, like, oh, what about this specific compound or what about this specific drugs? And they're like, let's add it to the list. We're going to move on and test. So I think it's very innovative of you guys to be able to keep digging for that data to, again, at the end of the day, is to offer people like me, a pharmacy technician, protection, right? So it's really great. I'm going to finish with this slide with saying that we need to have appropriate training. So 795 and the basic tasks of doing non-sterile compounding, you know, it's something that every pharmacy professional will see. We can commonly see that in every pharmacy practice. Mixing creams together, making a suspension that's non-hazardous, so we can have appropriate training. The environment's not going to be as complex. The minute we slide into that hazardous drug environment, there's acknowledgement of risk. We need to understand decontamination, what PPE to look for, what am I purchasing, how am I training staff, how to use this equipment, clean this equipment, decon the equipment, clean the room, like I can go on and on and on. What if there's a spill? So we need to make sure that there's all that training. Now, I know this might be a bit overwhelming, but we'll talk about that in a second and how you can have some support. So for closing points, we have our USP chapters, we have our NAPRA Model Standards and our guidance document. We want to make sure that we're following and compliant with them. And yes, this does apply to even someone that does occasional hazardous drug compounding. You have to follow. We don't want to make any exceptions because, again, even if it's one time, but at that point you're not protected, you're fully exposed, that could cause negative health outcomes. So we want to make sure we're following and compliant. And if you can't make it, it's okay. Send it out to a specialty pharmacy that can do it. Again, we talked about how hormones are super dangerous, so we need to make sure that we put in the right controls in place to protect our staff. And it even comes down to the people that are filling out dosettes or weekly patient schedules where they're filling out their weekly pills. I've seen some assistants or technicians that are counting out estradiol pills with bare hands. They don't even have the gloves. Or even if they're using a non-sterile glove, make sure it has some sort of ASTM rating so we know there's there's permeation data. So make sure you're not doing that with bare hands. Like think about that, even tablets, like we gotta think about all that, especially hormones. So now we know we talked about what doffing is gonna be, how we're gonna contain that hazardous drug residue. We talked about decontamination, same thing, that's gonna reduce the residue. So we wanna do that, put that in place. All that training that's going to be necessary is going to be super important. And I'm going to finish out with this. This was maybe overwhelming for some of you. Some of these might have been, for some of you, might have been a check-in. We know that this is a lot of information, but if you need any support, so my company, Critical Compounding Resources, we offer support with like construction design and training. Contec has the support with the PPE, the decontamination residue. So together we can offer support to those of you that might be new to this, some of you that just want to be compliant, those that are building out a new suite and want to take on that endeavor. Please reach out. We can offer support services for you guys. So I really wanted to finish with that so that you don't feel overwhelmed. And of course, I'm going to switch it to this beautiful slide. I know some of you know me and know that I love horses and I'm a horseback riding instructor, so I had to sneak that in there. And I did put my contact information out there on that slide for you, so if ever you want to reach out and have any questions, that'd be great. So I think we're going to throw it back to Michael.
Yep, thank you, Melanie. So we're going to thank you for everyone submitting your questions. You've been submitting them in the chat, and even some of you as you registered. So we're going to invite Melanie and Kadar to come and join me over here on the set. And as a reminder, following this Q&A panel, we'll have our dwell time segment that'll specifically address Contec products and how they can be used for 795 community pharmacists. So we've got our panel together here, and I do want to tell everyone that we're approaching the top of the hour. All of this is being recorded, so you can come back and watch it later. But we do want to take 10 or 15 minutes and try to answer as many of the questions that you submitted as we can. So you guys just want to jump right into it?
Absolutely.
All right, let's do it. All right, Melanie, I'll start with you. 795 seems to regulate larger scale operations. How can we apply this to smaller that may only do one non-sterile compound a month?
So that's a great question. We talked about that occasional compounding. Now, if it's for hazardous drugs, we can't make that exception. Oh, I'm only doing one a month. If it's a hazardous drug, it's a potential hazardous to you, the operator, the compounder, the person final checking. For the environment, is it exposing patients? So for hazardous drugs, to me, you must be fully compliant with 800. Now, what are you talking about? The occasional. If it's not hazardous and you're making a cream, mixing two creams together, making a suspension, 795 addresses just designated countertop and other little requirements where you can do your non-HD non-sterile compounding in there. So as long as you're following all of the 795, you can do that. You don't need a full separate build out of a room. You don't need negative pressure or anything like that for non-hazardous.
Yeah, and I think that maybe that question even stemmed from those that don't have the money to invest in it. Maybe they're farming it out. Maybe it's a veterinary clinic that needs to be able to do that. I know you love horses, so I'm sure that our fur babies take precedence as well.
Yeah, big, large operations, like especially for veterinary compounding, there's a lot of those taking place. So if the small mom and pop operations or smaller pharmacies or rural pharmacies can't accommodate that, there's usually specialty compounding pharmacies. Some of them are dedicated only to veterinary compounding. So then it might be best to outsource to them because they know. But if you're rural and you're the only pharmacy, you might have to find a way to make it work. Again, I'm talking non-HD. In HD, to me, there is no exception to any rule. We must be fully compliant.
That makes sense.
All right, Kadar, for 795, what is the recommended frequency for cleaning walls, ceilings, and floors?
Obviously, 795 USP gives us kind of that minimum standard. So there's always a best practice, right? So they say when it's visually contaminated, right, on a quarterly basis. Try to do it with your storage bins as well, but that's cleaning. There's the aspect of what you were talking about. If they have an 800 overlap, that's a totally different ballgame.
Yeah, we're going to need to implement decontamination procedures. And I know 800 talks about deactivation, decontamination, but let's focus on decontamination. So we're physically removing that HD residue from the target surface. So I think that's going to be important. But yes, you're going to want to do your high touch surfaces. You're going to be compliant with 800 with this. The CVE or the CPEC that you're using, you're going to need to do the ceiling and walls. I know it says occasionally, but we would recommend every 3 months for the decon, but the floors will need to be deconned every day.
Yep.
The floors can contain quite a bit of hazardous drug residues.
Yeah, that's a really great point on the floors. You just think about where it's most likely to end up, and like if it's there, where's it most likely to be spread from, and you just the foot tracking that stuff all throughout the facilities is pretty amazing. All right, Melanie, they're asking about the reproductive risk for compounding. Can it be level A?
Yeah, so the level A comment is definitely from a Canadian guest. So yeah, level A unfortunately cannot do hormones. So it is considered a hazardous drugs. I would definitely recommend that you need to be compliant with level C. There is some mention in level B for some occasional compounding that could maybe take place in a level B room with proper, but it's not going to have negative pressure. You're not going to have the requirements for the air changes. You're not going to have a doffing line, decon procedures. You're also going to be compounding non-HD stuff in there. So it's best not to mix the two. And then if you are doing any type of reproductive risk, so those hormones, full level C containment or 800 containment.
Is there a way, I mean, maybe not exactly, but for the US audience, what level A or level C means broadly?
Yeah, so level A would describe like, again, like just a designated countertop. For us in Canada, it would be like cream to cream mixtures. And then for level B, it would be a room. It doesn't have to be vented, negative pressure or anything like that. And then adding a CVE if there's any respiratory risk. Again, non-HD, and then level C definitely defines it as hazardous drug, non-sterile compounding. So we don't mix our non-sterile is completely separate for HD compared to 800 tackles HD and HD, non-sterile, and sterile in the same chapter.
Yeah, and for our U.S. audience, Kadar, I know you get a lot of questions about any information on use of our Contec products if someone's pregnant.
Oh yeah, absolutely. We would recommend going back to their medical professional. That way, because we don't know anybody's health history, so if there's an opportunity to take the SDS, how you're going to use it, the frequency, and take that information to your medical provider, they're going to best assess, that risk assessment. And if you can also, some of these individuals are the same individuals, right? But if there's a task that they can be repositioned to, that'd be great too.
Mm-hmm.
Melanie, I think you may have sort of answered this in an earlier answer, but can an HD hood be used for both sterile and non-sterile compounding?
Yeah, so there is that little mention of the occasional. So again, that word is hard to define in a number, because what's occasional for my pharmacy might be different for someone else's pharmacy. Like, is that once a week or once a month, once a day? What's occasional? So to me, the minute it starts to begin to be a routine, we need to have separate seats. Now, if we all had the money and we could do what we wanted, of course you would build out a separate suite. I know why you're asking this. Maybe you're a rural pharmacy or a rural hospital, and you have a sterile access and you're going to use it. It is allowed per 800 and in NAPRA with that occasional little caveat, but you do need to implement full decontamination of the entire CPAC included under the work tray, then full cleaning and disinfection, and then sanitizing as well. Or sorry, we don't use sanitizing in the US, but residue removal with the alcohol. So that usually, if you have a BSC, that could take up to 40 minutes to do all of that.
Just briefly on that, they asked about the line of demarcation that we put down. That they were wanting to confirm that that's not a requirement like it is.
No,
so
it's a best practice. 800 does talk about it in suboptimal designs, but in sterile applications. But we're absolutely going to recommend that a doffing line be put in as a best practice, because how else are you going to stop the residues from crossing over into your non-HD spaces?
That's a good point.
Kadar, I think this question came from our pre-game show. They were like, what non-compliance issues did you see out there?
Oh, there's all different types of complete gambit on that. Anything from just like we mentioned, there's some best practice, but there's some non-compliance of maybe where they're cleaning some of these utensils, what agents they're using to quote unquote decon. If they're deconning at all, because it's just a complete Wild West right now. But I think everyone there wants to do the right thing too, and I think they just need to understand that here's someone that we can go and talk to, whether it be our core products or something that can help them. We're not trying to reinvent the wheel. We just want repeatable process to protect their employees, right? And that's really what it boils down to. So I'm not going to single out a lot of non-compliance things, but I do think that there is importance of understanding the risk, because that is really critical for that business owner. This is an employee, right? So there is a health risk for their employees that we really need to try to address.
And while $7.95 isn't new, people are taking on that responsibility, I think, a lot more now. I think it's a lot more state boards are being more proactive, therefore the pharmacies are being more proactive. But we did get an update to that chapter, so I think that sort of kicked off a lot of what we're seeing.
I also think that 800 becoming official pushed things like, oh my God, like maybe some of the non-sterile compounders never really knew about 800.
Right.
And then all of a sudden they're like, oh, well, now it's become official in 2023. So it's like, oh my God.
Well, the hormones alone, not being on the list, where a lot of the focus was. So I think that also these individuals that are using some of these new products, they may not understand that there could be some complications to their current work environment, right? Like whether it be negative pressure or maybe legacy equipment that might have some damage that this new chemistry might highlight, maybe some fittings that are not compatible with the chemistry. So there are a lot of watch outs that we can help that customer base with what we try to present.
Melanie, this is right up your alley because it deals a lot with training. What simulation compounds are facilities using to observe non-sterile compounding?
Right, so I think that plays more to like initial training, so when we're onboarding new staff. So when we do that simulated compounding, a lot of the times what I've seen is like people will use like a lactose powder as an API because technically that's not a real active medication. So using an excipient can simulate that. You can also buy lactose tablets if you want to simulate making a suspension. So because technically we don't want them compounding for a patient use, so human or veterinarian or animals right from the beginning. But after that, when you're just doing the competency assessments as you go on and you're just validating some of their techniques, then you can just be watching them do a compound, even if it's for a patient. It's mostly more for initial that you'd want to simulate. So yeah, using those the excipient powders and getting those tablets, you can use that to simulate.
All right. This next question is for both of you. And this honestly came up, I would say, 10 or 15 times in the question. So we'll put them all under the giant umbrella and let's just do this generically. What are the best ways to wash reusable hazardous compounding equipment?
All right. So this is a topic that can be a little difficult to answer. So we know that 800 tells us that everything coming out of that CPEC, CVE, BSC that you're using for non-sterile or sterile compounding needs to be fully decontaminated before it comes out. So we have that. But then we also have the reusable tool piece where we need to clean it because in sterile compounding, we're not washing reusable tools. So what I did is I talked with Dr. Mark Weinsack, I talked with an industrial hygienist, I talked with my business partner, Mary, and I talked to a lot of different people, and I've come up with some steps that I think would be best. Now, none of this is data-driven right now. We're just putting our best guess forward. Until we have a data-driven answer, I'm just using expertise as an opinion. So first of all, it's going to be important that we use disposable tools when possible. You can buy disposable stir rods and spatulas and weigh boats. So again, we want to do that, and then we can dispose those in the RCRA race. Good to go. But there are tools that we may not be able to do that, or some of them might be super costly to purchase as disposable. So example, a mortar and pestle, some of the graduated cylinders. So those need to be cleaned out. First thing you're gonna wanna do is grab a dry wipe. I think it's best to use dry because you're gonna not wanna remove the gross contamination, leftover residue of an ointment, a suspension. You're gonna wanna remove that until you can no longer see it anymore. From your mortar and pestle, it could be from your graduated cylinder. You wanna wipe and let that drain all the way out till you physically can't see it anymore. Once that's done with the dry wipe, that has to go in your RCRA or cytotoxic waste for Canadians. And then we're gonna wanna apply a decontamination agent, whether Paradox, and you're gonna wanna apply that twice. Now you're saying, oh my God, we're already up to 3 steps now, Melanie. And I'm like, yes. If you wanna go down to a 1 step of your decon agent, you would have to implement HD wipe sampling and validate that method. But for right now, I don't have data, so I'm gonna tell you to do 2 wipes down to be very thorough. And then after they've been wiped down, we can remove our outer gloves and then transfer them out of the CVE or the BSC, and we're gonna take them to a hot water and dish soap supply, so your sink, so we can do a wash of that. After that's done, we're gonna want to do, so 795 and NAPRA do speak to a purified water or a distilled water or reverse osmosis water rinse. Again, those are gonna be used for oral formulations and topical, so we're gonna wanna make sure we're removing any of those potential residues, the last parts of the potential residues, and allowing them to dry. So one thing I do wanna say to be very safe is like what you're doing with those reusable tools in the sink and allowing to go into your wastewater, please make sure you're following your local and municipality rules and regulations on what type of waste and residues in those waters can go down your drain. So please make sure you're following that. And also those of you that are using dishwashers. So we've talked about that a little bit, Kadar. So we would never recommend you use a dishwasher for the reusable tools with hazardous drug non-sterile compounding. We do often see dishwashers, like even a household dishwasher for non-sterile non-hazardous compounding, and that's totally fine. You still want to remove the gross residue, no need for paradox at that point, and then you can use a dishwasher. Still recommend a purified water or reverse osmosis distilled water use, but not for hazardous drugs. So yeah, sorry, this was a long answer, but I really wanted to make sure I get that across. And again, if you're questioning the process and want to modify the process, do your own HD wipe sampling, which I do recommend for non-sterile HD compounding. I think it's an incredible tool. We should be doing it and monitoring those surfaces for how much residue is left behind. And then that's how you can justify if you're modifying this process.
Yeah, I think Dr. Mark Weinsick is in there and probably heard us to try to get that data for maybe a limited pass for these type of these reusables, I should say. So hopefully we'll get you some data, but your expertise on that is very much appreciated.
Yeah, that's a tight process. All right, so we've just got a few more minutes here, and there were some people seeking clarification on some of the doffing demos that we did, so I'll handle this one. USP 800 requires 2 layers of shoe covers. In your demonstration, I noticed only 1 layer of shoe cover is worn. So USP 800 has its own regulations. It also says follow 797 or 795 for what's appropriate. So the 2 pair of shoe covers is really for the sterile compounding pharmacy. So if you in your mind envision, I've gone through my anteroom through the donning process, and I've gone one way into my HD space. So I'm doffing out of that chemo gown and the outside pair of shoe covers and the outside gloves inside of that HD room before I come back into that anteroom, the clean side of the anteroom. I don't want to walk into that space with no shoe covers. So that double booty requirement I love that phrase, double booty, comes from realizing you don't want to go get outside of that into that ante space. So in our example today, a non-sterile pharmacy, once we cross, and it's not even an LOD, that perimeter line, the dirty side of that line, that is an uncontrolled space.
That's right. So there's no requirement for sterile. So that's why we can go right to our shoes. And then just a little same thing, there's no need for microbial sampling or anything else in these environments. We're not considered sterile compounding.
And same example here in your doffing example, the hairnet and a second pair of gloves were left on when exiting the room and to be discarded for coordinate 800. PPE worn during the compounding process should be disposed of in the proper waste container before leaving the CSEC. That's it, the SEC, that controlled space. So again, that's 800 telling you to follow, if you're doing sterile, also follow what 797 says, but also if you're doing non-sterile, follow what 795 says.
And
that's right.
I think that's what you were mentioning earlier. NAPRA does a pretty good job of laying that out, where this is like a blanket kind of covering multiple steps. So, we're there to help, so let us help you navigate through that.
And again, you have to do what's best for your facility and your procedures. The goal is to not have any hazardous drug residue come out of that room. If what you're doing is working, validate with HD wipe sampling, good to go. Then even if an inspector were to ask you about your procedures, you can show them the data on why you did it that way,
exactly
and then
right.
make sure all your employees are doing the same, and that we document in the SOPs.
Yep.
That's key. I'm sorry, Michael. The SOPs are key. Documenting in there.
Yeah, that every employee knows what's expected of them, and also someone's checking to make sure sure they're doing. And then the last thing on this, Don Doff was, where did he toss that inner glove and befont mess? Does he need to put that in trace waste or regular trash?
We would do trace waste just because it's been in that environment. Anything that's been in that environment, except for you as a person, don't need to go in the trace waste.
So you would have a second trace waste, because that perimeter line, we had the can in our example today was on the clean side of the perimeter line, on the compounding side.
The non-contaminated,
And so we doffed out of the gown there. If we cross over that perimeter line, you don't want to sort of be tossing back in there, so have another trace waste.
Yeah, but again, depending, like some of these places are working with very small rooms, so that doffing area is going to be small. You can, and again, if you want to remove everything within that space, that's totally fine. Because again, if we expose hair, or it's not sterile, so it's okay to do it all in there and then exit the room. It's whatever's going to be best for your facility. Again, just validate with data.
We've run out of time. We're not going to get to all the questions, but someone will be back in touch if you've left a question. And Melanie, I just want to say thank you for packing a lot of info into a short webinar, but it still just feels like we barely sort of scratched the surface.
Yes.
So you mentioned at the end, you're available for support. We're at Contec is obviously available for support. So it's really reach out to us when you need that help. I can't go another second without thanking the folks in our studio control room back there. Daniel Crow's entire team, Chris Ebert and Ryan Goodman. We also had a lot of help from our marketing folks out there. Thank you, Dylan and Jody. They were sort of manning that chat and making sure we were fed all of the questions up here. So those folks help us make this learning engaging and really a lot of fun for you at home to watch. So again, couldn't do it without the support of that staff. Also, a quick reminder, coming up in about 2 minutes is our post-webinar session called Dwell Time. We'll have 2 Contec experts on here. This is your chance to ask about Contec products. Perhaps you want to get some samples to work through some of the stuff that we discussed here today.